Rotation and some changes in the sagittal alignment as well. And generally, when we talk about the treatment for how to treat this triplanar deformity, we have some general rules on the Cobb angle in the coronal plane. To say up to 20 degrees, let's only do observation and exercises. Up to 45 degrees, let's do bracing and exercises. And then after that, we do surgery. And generally for the treatment options, we have, when we talk about treatment, at least almost a decade ago, it was only fusion. And you can do it anterior fusion, posterior fusion, or selective fusion. And actually, we were very good at this. See an example where we have a deformity in the coronal and sagittal plane. We plan our surgery and we do a correction in all three planes. We also correct the places of the spine that we actually don't operate on, like in the example of reciprocal change in the cervical area. And in another case, again, the planning and the surgery. As you can see here, we can really do a very small amount of surgery compared to the magnitude or length of the curve. Or as seen here, we can do selective fusion where we have two big curves but operate only one. So all of these were really good, still very good, but there are also some disadvantages of fusion as well. So there is limitation in motion. There may be limitation in growth if you do it too early. There may be adjacent segment problems, disc problems. If bone healing does not occur, we can have rod breakage, pain, or loss of correction. We can have muscle weakness. All in all, this is not actually a very physiological treatment method. So our spine is designed to move, but when we do fusion, we stop the movement. Although we know that we don't have very high complication rates, actually, and in some cases, where the curve is very big, it can really be a life-saving surgery. It is not an evil, but today we want to focus on motion more. So we want to think about how we can do fusionless treatment of scoliosis. So after this introduction, let's go back to several years, like 500 million years ago, and say, how did these vertebrates start to form throughout the timeline? And we can see that all the vertebrates have been kyphotic in the lumbar area. So until very recently, in 2.5 million years ago, with the Homo species, we started to have a lordotic orientation in the lumbar area instead of the kyphotic orientation throughout the spine. And actually, this still up to today, the lordosis of the lumbar area is only unique to human beings. And when we are a fetus or a newborn, it's actually not present. So when we start to crawl, and when we stand up, this lordosis becomes evident as a secondary curve. So this actually has changed the way the spine is being loaded, especially in the lumbar and thoracolumbar area. So up to when the human has stand on the 2 feet with a lordosis area in the lumbar, the shear forces were always anteriorly directed. But for the first time, now we have a posteriorly directed shear force in our spine. And we know that if we have more loads than we can carry, if there's an excess of posteriorly directed shear loads, this creates a posterior and rotational instability, which in the coronal plane turns into scoliosis. And not today's topics, but Scheuermann's and spondylolisthesis is also excess of loads in other directions. But for the pathogenesis, if we go back to the first slide, we know that this is a sideway curve, rotation and sagittal deformity, but how it is formed is first the sagittal plane and then the axial rotation, and then actually the coronal plane curve comes into play. And when we look at when this scoliosis happens, it's actually, we have two main times when we get scoliosis. First in growth, And then for many years, we don't have too much scoliosis prevalence. And then with degeneration, we get more. But today's topic is the one that's happening through growth. And if we check what growth is, so when we are born, we have a lot of growth, almost 20, 24 centimeters every year. And then up to 5-6 years, it decreases. And then there is a stable zone. And then there is the adolescent growth spurt, which we start growing more rapidly again. And as you know, we grow through the things that are called the growth plates. And what's funny about growth and growth plates is that because of these zones are tolerant to loads, what we can do is actually we can change the way we grow. So the growth is a thing that can be modulated, and it depends on the loads acting on the growth plates. Like in two examples here in China, like the foot binding, if you apply compression on the growth plates, you make the growth less. So you can diminish the growth. And on this example here, on the Padang woman, when you have the neck rings, it shows us that when you do traction, you can actually gain more growth than it's expected. So as shown here in the diagram, we can compress and we can apply traction and then change the amount of growth that we are going to have. And this is known as the Hütter-Volkmann law. And in scoliosis, what happens is because the sideways curve and the body loads are in the middle, we get a spinal curvature, asymmetric loading, and this asymmetric loading, as shown here, causes growth asymmetry and wedging of the vertebra, and then this creates a vicious cycle described by Stokes. So this is the compression, the wedging. So if we go back to the 3 slides that we had in the coronal, axial, and sagittal plane, so if we were shown in this like red example, exactly same anatomy, but in a different position, then we could call scoliosis a postural disorder. But actually the truth is, when scoliosis is happening, what happens is it changes the anatomy, it changes the shape. So, and also this is true for the ribs and other adjacent bones as well. So the way we grow changes in the right and left hand side, in the anterior and posterior side of the vertebral body. So we get a triplanar growth asymmetry that changes the anatomy of the spine. So if scoliosis have a pathogenesis like this, what we can do is we can try to get rid of this load distribution and we can try to reverse how scoliosis happens. So we call this the growth modulation. And what we do with braces is we apply compressive forces on one side of the spine and then try to elevate the other side as shown here. And we gain compression and distraction on the opposite sides that were previously present. And we try to make it in the midline to have the loads distributed equally after the treatment has started. And in the clinic, we can see the change in the growth of the soft tissues and bony tissues as well. So in order to do that, we have to also estimate the skeletal maturity. We have to understand how much growth the patient has. So these are several things that we can use to do that. We generally use the elbow or the hips to estimate that. And when we do not just compress on one side, because this is a triplanar deformity, but we do it in a triplanar fashion. We do a 3D correction, elongation, and what we actually also do is we use the breathing mechanics to get more correction, as seen here in these video examples. And how this acts is, if you apply compressive forces on these corners, you get some correction with the brace, but then with the breathing mechanics, you get more correction. So if you look at the results of what we can do with growth modulation, with bracing, is actually dependent on the curve, location, magnitude, and flexibility, the design, and the compliance of the patient. And you can see here that this brace was able to diminish the load distribution problem that was apparent here, but now they are in the midline. But this is also a good correction in the coronal plane, but you can see it's not aligned, so the results are not as good. And here you can see that the spine is in the middle, and also the breathing mechanisms work, and you can get the results. So the correction we do and the modulation of growth we do is dependent on many different factors, but mainly on the midline alignments, but not only in the coronal plane as shown in these examples, but also the success of growth modulation is also in the sagittal plane and axial plane. So if we can correct the altered load distribution in the coronal plane, and also the load distribution, if we can make it better in the sagittal plane, so this is how we can get a three-planar growth modulation. And this is how we can actually, with conservative treatment, with braces and exercises, we can get three-planar correction in the scoliosis. And as this is a growth problem, we know that when you grow older and when the cobangles get bigger, the chances of getting a success is lower compared to being younger and smaller degrees. We get a more chance of modulating a growth and having a success. So these are generally, like, the typical example is where we start and where we end are quite similar at the very end, because generally when the scoliosis is big enough for us to diagnose, it's probably somewhere around 25 to 30, 35 degrees already. But the main goal is to decrease the number of surgeries. And this is an example where we can see an extreme case where we started at 8-year-old at 62 degrees, definitely a surgical candidate, but 2 years later now has a 42 degrees curve, and then we will keep doing the exercises and braces. So in summary of the part about the braces, this is an indirect growth modulation method because the forces are not on the vertebra. The forces are generated through ribs and soft tissues. So if the curve is too big, or if the curve is very rigid, the growth modulation with braces is not strong enough. And it may not be efficient enough if the remaining growth is not too much. So let's see the other example of how we can modulate the growth. It's called the vertebral body tethering. So what we do is we place screws on the convexity side of the curve, and then there is a tether or a band which we tighten to apply compressive forces directly on the vertebral body. And there has been a very big, biomechanical studies, animal models, and science behind it after first human cases, and then now today we are doing the case series. And exactly the same modulation that we did with the brace is what we do is we place the screws and the tether, and when we tighten, we can change the way the Hütter-Volkmann law acts. The compression and distraction sides are changed. So after the surgery, spontaneously, the curves correct over time because there's the compression and distraction are on different sides. So let's check this in an example. 6 weeks after the surgery, you can see the height of the vertebral body in the convex and concave side. And 1 year later, you can see the amount of growth modulation we get. So this side is growing less, but the other side is growing more. So now we are almost getting back to a rectangular shape in the vertebral body. So how we do it is we do it by video-assisted thoracoscopic surgery using keyholes, 1 to 3 centimeter incisions. And when we are applying corrective forces from outside using these hand devices, we apply tightening from the inside. And we can do our also revisions if we have any problems with the same method with thoracoscopic application. So just a quick look at what we can do, how much growth we can modulate with this technique. We looked at our cases and we grouped them into different stages of their maturity and growth potential. The juvenile cases, pre-adolescents, early adolescents, late and early mature. And we have shown that these different groups, they actually grow in their height, like 13 centimeters, 5 centimeters, 3 centimeters, or 1 centimeter, according to different groups. And also they grow in the part that's actually operated. And this growth has shown, so these are all the cases, this growth has led to correction over time after the surgery. And this is the graph that has all of them together. So the one patient that was Sanders 1 that grew more than 20 centimeters had actually more than 45 degrees of correction, while different Sanders group, as they grow less and less, they had different magnitudes of curve correction in the coronal and also in the 3 other planes. So the take-home message of this talk is that lordosis is unique to humans, and it has changed the way our spine is loaded. So this is why human beings are the only species that can naturally get scoliosis. And scoliosis is a 3-planar growth asymmetry. It's not a postural disorder. And this growth asymmetry is not only in the spine, but also in the neighboring bones. And the good news is that growth can be modulated, and we can do indirect modulation by exercises and braces, or we can do direct modulation by vertebral body tethering. Thank you.
Thank you, Mr. Yılgör. It was a very nice presentation. And our second speaker is Professor Dr. Ahmet Alanay. He is also, he is the medical director of the Comprehensive Spine Center at Acıbadem Maslak Hospital in Istanbul, Turkey, and also a founding member of the European Spine Study Group. He will present us the internal bracing, the anterior vertebral body tethering. Mr. Alanay, the screen is yours.
Okay, thank you, Deniz. Good afternoon, everyone. I would like to thank for your very kind invitation. And so Çağlar actually has introduced vertebral body tethering and the biomechanics behind that. So I will go straight to the indications. The original indications has first been defined by the Shriners Hospital case series after 2012. And this was also the indications that we began our practice. So patients with idiopathic scoliosis, usually or preferably older than 10 years old, with remaining spine growth are the candidates for the surgery, and they should also be between RISER 0 and 2 with Sanders stage 4 and less than Sanders stage 4. And the thoracic curves between 35 degrees to 60 degrees were determined in the beginning of this practice as the best candidates for this surgical method. And there was one prerequisite which was really important, and the curves should be flexible below 30 degrees. So by starting with all these indications, and once getting more confidence within the technique, we have expanded our indications, and these are our current indications. But the previous indications have recently been approved partly by FDA in the United States, but our indications are quite wider than what FDA has approved. So we do this surgery, we perform this surgery for patients between ages 10 to 16. And as Çağlar has mentioned, according to our retrospective review of our cases, so we defined 2 patient groups who might be good candidates for this sort of surgery. The first group were those patients with rapid growing growth potential, and these are usually premenarche RISER 0 to 2 patients with Sanders 2 and 4. And the second group, which can still be candidate, but maybe not the best candidates, are those patients who are in post-menarche less than 2 years status, RISER 3, 4, and Sanders 5, 7. So we have expanded our upper threshold up to 80 degrees. And also we have started for lumbar curves since 4 years. So we perform this surgery also for lumbar curves as well. And these curves, the threshold are between 40 and 70 degrees. So again, at least 50% flexibility or bend to less than 30 degrees are one of the most important prerequisites to do this surgery. And preferably patients should not be very hyperkyphotic, as this is a kyphosing procedure. There are some expanded indications that are used by some surgeons throughout the world, a few of them. And this surgery, some surgeons have started performing also for adult patients over age 20, and for some rigid curves over 80 degrees by doing disc cutting and rib cutting. I'm actually not there yet because I think this should be a very physiological solution for scoliosis, definitely non-fusion solution, and which should be done with a minimal invasive approach. As in the title, it should be kind of a internal bracing. So I believe this cutting can cause early disc degeneration and eventual spontaneous fusion in the future. And if not, it definitely creates instability. So I don't like disc cutting in those patients. And also rib cutting can cause compromised pulmonary functions, which is also something that we don't want to see, after managing scoliosis cases. So typical indication, this is a rapid growing patient, pre-menarche research 0 Sanders 3. As you can see, there are 3 curves, 46 degrees of main thoracic and 33 degrees of upper thoracic and 35 degrees of lumbar curve, which is a lanky type C curve. So what we have done was to correct this patient to 30 degrees with the initial surgery. But as you can see, at 6 months, 2 years, and 3 years, we had a very nice spontaneous correction in this patient, not only in the main thoracic curve, but also in all 3 curves. And here are the clinical pictures of this patient. As you can see, there is no scar incision at the back. This is another patient, this time Sanders 2 with more growth potential. In those patients, after seeing some overcorrection, now what we do is just get a very small amount of correction, which will be starting the Hütter-Volkmann law to function. So as you can see, we have corrected this curve only to 34 degrees, but by time, 6 weeks, 3 months, 6 months, 12 months, 18 months, and 2 years, the patient is at Sanders 4, still having some growth potential, but the curve has had a very good spontaneous correction. And here are the clinical views of this patient. So we do this as a multidisciplinary team approach, and we include a cardiovascular surgeon and thoracic surgeon who are helping us to show the operative field. And as Çağlar has mentioned, this is a keyhole surgery that we do with the aid of video-assisted thoracoscopy. So our experience, this was a presentation that I prepared a couple of months ago. So I think we have more patients than this, but we have done 102 VBT surgeries, and 52 patients at least has reached more than 1 year follow-up. And we have longest follow-up of 66 months. And these are the demographic information. As you can see, we had a very minimal amount of bleeding, especially compared to posterior fusion in this case series. And there is no conversion to open surgery, no disc release, no resection in this case series. And we had 42 patients with more than 1 year follow-up, all thoracic only patients, as these in first 42 patients, we did only the thoracic curves, not the lumbar curves. So then we just analyzed the results with our 42 patients. And as you can see, especially in the rapid growing patients, those patients up to Sanders 5, less than 5, as you can see here, we had a very nice correction, actually a controlled correction to around 20-25 degrees with the index operation to avoid overcorrection. And as you can see, by time we had some more spontaneous correction, and as the sum, the total correction rate was 75%. So we had a mean hump reduction at follow-up almost 50% and mean height gain of 8.1 centimeter. But I should remind that these patients are still growing, so probably we will have more than even more than 75% of correction at the end of the growth and when they reach to maturity. So the mean compensatory curve, the untouched curve, which is the thoracolumbar lumbar curve, had also a total of 64% of correction, where all the correction was spontaneous correction as a reciprocal change in the beginning, and then again there's another reciprocal change which was following the spontaneous correction in the main thoracic curve after the index surgery. In sagittal plane, we didn't have too much change, and we were able to create some kyphosis. And interestingly, although we opened the chest as we did this minimal invasive keyhole surgery, all those patients had at least a 7% of increase in the forced vital capacities, which was also a very encouraging result. So this is one of our, and another sample of our rapid growing patient. The main thoracic curve of 51 degrees was corrected to 18 degrees at the end of 2-year follow-up. And you can also see the satisfactory cosmetical result of this in these clinical pictures. And regarding the steady growing patients, the main thoracic curve in the index operation, this time we tried to correct as much as possible within the index operation. So we got almost 50% of correction with the first surgery. And then by time, as those patients didn't grow as much as the rapid growing patients, we had only a 4% additional spontaneous correction, which ended up a total of 57% of correction rate. And again, in the hump reduction, we were able to get a 50% of correction, and they got some height growth as well. And looking at the compensatory curve, again, we were able to get a 62% of spontaneous correction in the thoracolumbar and lumbar curves. And again, in the sagittal plane, we had some kyphosis restoration. And interestingly, again, although those patients did not grow too much and there was not too much thoracic cage development, those patients also improved in forced vital capacity. I believe this was because we did a non-fusion surgery, which allowed the ribs not to be included in a fusion mass and continue to open up during the respiratory motion. And this is one example. 43 degree of scoliosis was corrected to 19 degrees. In the first 3 months, as there is some slacking in the cord, we had this increase to 25 degrees, but at the end of 2 years, as you can see, we ended up with a 2 degrees more correction, and the patient ended up with a 17 degrees of main thoracic curve with a satisfactory correction in the clinical pictures. This was an elite level gymnast, and this was a little bit tough case as the curve size was too big, but we were able to get this much of correction after 2 years, and this patient is still continuing her gymnastics career. And also the clinical view was satisfactory with a satisfactory amount of increase also in the SRS subtotal score. So regarding complications, we had thoracic complications, usually pleural effusions in almost 7% of patients. There were some mechanical complications, which was mainly overcorrection in the patients that we did in the very young ages. And total complication rate was 14%, and 30-day readmission was 1%, and reoperation rate was 3%. This is a patient, Sanders 2. So as I mentioned before, we do right now less corrections due to the overcorrection complication in Sanders 2 patients, or we just try to buy time by doing bracing and short exercises. But unfortunately, we correct this patient to 22 degrees, and by time, as you can see, 18 months later, the curve tended to turn to the other side. So we decided to cut the tether at the lower end with a second thoracoscopy. So that was a successful operation. So this patient ended up at the end of maturity with a 10 degree of residual curve, and from 49 degrees to 10 degrees in 3 years, and with a very satisfactory clinical outcome as well. So what is the role of PT and braces for VBT? We are actually benefiting the physical therapy exercises and braces for VBT more and more in those days. And our main aims are to buy time for Sanders 2 patients or very immature patients, to increase flexibility to get the best curve correction and degrees of tension on their cord for rigid curves, to initiate or accelerate Hülter-Waldman law and spontaneous correction in very few unresponsive patients and patients with increased curve sizes after the index operation, and this really helps us a lot in reversing the curves to better control and avoid the increase in untethered lumbar and thoracic curves and to accelerate rapid recovery. Some examples, for example, this patient, the lumbar curve is also quite rigid, and many surgeons today would do a double tether in this patient, but I try to avoid the tethering in lumbar supine, as most of the tether breakages are occurring in the lumbar supine as it's very mobile. So after doing this surgery, we have braced this patient and we have put her also in some short exercises. And as you can see, we had a very nice correction in the thoracic curve, and brace and exercise helped us also to control the lumbar curve with also some help of the reciprocal changes as a response to the correction in the main thoracic curve. So we ended up with a nice curve correction in both curves and with satisfactory clinical results. This is another patient who was really very young, so I tried to avoid doing surgery for this 45 degrees of curve, and I tried to buy some time by doing exercises and also the braces. As you can see, we were able to control also the lumbar curve, so we had the advantage of a decreased lumbar curve by the exercises. So we did only main thoracic curve correction, and this patient is doing well and still under control with some growth potential. So in summary, advantages of BBT are motion preservation, growth sparing, scar, hidden underarm, bra, short hospitalization and rapid recovery. And the disadvantages may be listed as no long-term results, may necessitate multiple surgeries due to complications, less hump correction in patients with no or less growth potential, especially compared to fusion procedure. But especially for such a patient, an elite gymnast and dancer with a 45 degrees of curve, I actually was not very comfortable doing a fusion surgery. But with such a kind of surgery, as you can see, this patient completely turned back to her sportive activities in a very short time. So early midterm results offering minimal invasive feasibility and growth and motion sparing and having long complication rates with this type of BBT surgery is a promising alternative, but of course there is much progress to be made. Okay, thank you very much for listening to me.
Sorry. Thank you very much also, Mr. Alanay, and it was a great presentation. Our third presentation for today is going to be presented by diploma orthotist and prothetist Andreas Würsching from Croatia, who is the owner of House of Health company with his wife, Sani Bulat Würsching. The presentation will be about overview of the historical development of bracing systems and material and production methods. Mr. Würsching, the screen is yours.
Thank you very much. I want to thank you very much for this very nice introduction. And it's a pleasure for me to give you a little overview of the German upbringing in this profession, which is bringing us also always a little bit in the history, and at the same time to show you some kind of progress, some kind of line which comes over the years in our profession. We are mainly dealing here in Zagreb with children and bracing, but all kinds of bracing, so not only scoliotic and idiopathic scoliotic, but also other diagnoses. When going back a little bit in time, we see there are a lot of old techniques which have not changed so much. So we have, for example, the elongation, because very clearly it was that when the body gets shorter, we have to stretch it. There were some redressing systems, very cruel, very harsh, but the idea was to give a very quick treatment to the deformity which was observed in the children. Also, compression and stabilization was already in the beginning very famous. Of course, I have now missed out some of the antique and very old documentations. I was focusing now in my presentation a little bit on the last century and this century. Altogether, we can see a big development that we...
Andreas, so sorry, do you have some problems with the sharing of the presentation, or because we are not able to see your presentation.
What? Okay, wait. Why?
There is the share screen, okay?
Yes.
And then you have to find maybe your PowerPoint or desktop, I don't know.
I was doing it one like with Nicola yesterday.
Yes.
So,
did you see?
let's say, let's try this one.
Yes.
Okay.
You have to start with your presentation and then say share. Okay, good. There should be also a
Somebody else is sharing at the moment.
no.
Yes.
Okay.
So, okay, one more time.
Yes, please.
You see something?
No, not yet.
No.
Share screen, and then you have to see your desktop or Microsoft PowerPoint or something else like, yes.
What is now going on? Again, you don't see it. You don't see my screen.
Yes, we see it. You have to start with the slideshow.
Okay. You see now my screen?
Yes.
Okay.
Mm-hmm.
We go a little bit back.
A little bit.
So you see a lot of phrases. Deniz, do you see my presentation?
Yes,
now?
yes, I see.
Okay.
Perfect.
Let's try again. So sorry, I don't know what went wrong. What you might be now hopefully see are some pictures of old techniques for correcting the spine. So what you see is, for example, this elongation. What you see is a redressing. What you see are examples of compressing and stabilizing a body which was losing its anatomic physiologic shape. What we see over the years is that, over the centuries actually, that it was coming a decrease in manual craftsmanship, that less and less materials were used to make a construction, and typically accompanied by the materials which were coming or were developed during those ages. At the same time, especially now in the last, let's say, 100 years, we have a more profound and more documented research and scientific approach to scoliosis, which brings us much closer to better results, and then also to a more proven or documented way of constructing help for those children. We always have now a little bit to jump between Europe and America. Interesting, there are some parallels and there are some new things on each side of the Atlantic. Unfortunately, I can't go into all of those details I have found during my research, so please excuse if it will be very fast and very, very short. We start with Europe, with Lyon, with the French corset. It was, as a start, a post-operative method, a post-operative treatment to stabilize far in the age when an operation was really a big undertaking for stabilizing a spine, and the implants had to take time to heal in. Things we are now, as my predecessors of my presentations have pointed out, are quite obsolete in some of the cases. So what we needed here was stabilizing the body, and we know this shape, but very special here in the shape, please take in the view that we already see a certain symmetric shape. We want to have a body in a very natural symmetric shape, fixated, and achieving that by a compressing or redressing of certain parts of it. The interesting thing is that actually this technique has stayed alive, but it was developed. Colleagues in France and in Italy are developing and working with this kind, we call it super rigid braces, which are achieving quite a very impressive correction by, for example, nowadays making 3 scans, combining them together and forming a very close to natural physiologic shape for the patient. The material in this case nowadays is polycarbonate, and by the see-through of the material, the treatment can be observed through the brace, which is quite an interesting fact. Unfortunately, it's not so easy to wear those braces. The motivation and compliance has to be quite high. If we go back again a little bit now, in America, we had some similar movement or some similar development. Here we have in the Milwaukee brace a construction which was designed to stabilize post-operative situations after neuromuscular patients were operated. So what we have here is an elongation system, a system which was stretching or at least keeping the patient in a stretched position with fixation around the pelvic and above the head or the neck. The idea was, though, to stabilize again post-operative the operation results. But again, like in France, it was obvious that more and more before the operation, those braces were used as the pre-operation brace and the pre-operation brace. So we have here already the beginning of a what we would today call a conservative treatment with a bracing system. Also then in Boston was coming up another method, because once they had good results in treating patients with scoliotic, the numbers were jumping and they had a lot of patients to take care of. What they had to do was to make a lot of braces in a very short time. And there came the experience from the Milwaukee quite handy, because they saw that a lot of patients can be fitted with similar modules they were using for the pelvic basket. So they found out that while producing some braces ahead and keeping them in a symmetric, anatomically physiologic shape, they could very quickly serve a lot of patients by just having to adjust the braces in a short way. Still, these braces had a very nice physiologic shape. Please take care that you see those 15 degrees of lordosis already in the brace implemented. And we have here again the technique of compression, and by compression redressing the deformity. The problem was that, of course, with a certain verity, you never can take all the patients in just one module. So there are also, again, limitations to this type of fitting. We go back to Europe with Dr. Chenot. We would nowadays call him maybe the grandfather or the father of modern bracing. We had now the first time a step in a complete new direction. Now we are losing or getting away from the symmetric approach we have seen so far. Now we have somebody who takes every bone, every part of a scoliosis, and wants to push exactly this part of the bone, exactly this piece of vertebra into its correct place. The result was a quite compelling and quite complex set of rules where and how a brace has to be and to be formed. But for the first time, we have a very asymmetric brace, which also was only possible with the upcoming of polyethylene, polypropylene, long-chained polymers, which the thermoforming process was at all giving us as technician a possibility to make a model or to make a brace. Immediately, the Chenot idea, the Chenot philosophy was taken and developed further to special indications. So, for example, the Wiesbaden group was doing some constructions to attack high thoracic deformities or rotations with a CBW brace. Dr. Rigo from Spain was developing actually an own classification. This classification was, as far as I saw, the first classification for conservative treatment, for constructing braces. So that was a big step in the conservative, in the bracing direction. And with this classification, it was also possible to make service fabrication, so that you, by measurements and deciding which type of patient you have, you can, on the distance, provide bracing for patients which are actually not in your facility. Dr. Weiss, also a colleague a former colleague of Chenot and a colleague from Rigo, was developing several systems actually. Dr. Weiss was very much and strong involved in Bad Sobenheim. So in a clinic focusing on conservative treatment. So where he was putting his mark or his focus was on pushing on correcting the spine as far and as much possible. So we have here a modular system called the Scoliosis. So he was trying to have a disassembled model which then on the patient could be pushed as far as possible to achieve a correction or sometimes even an overcorrection. The next step for Dr. Weiss was, for example, I think my colleague in two presentations will go there a little bit more detail on it, on the Gensingen brace. We have here another classification which is doing by this classification and by the construction methods a strong and very pushing, correcting construction to the flexible spine. The whole world of Chenot is one of the most flexible and most modular parts of our technical collection. At the same time, it's also one of the most dangerous because with Chenot, with the Chenot possibilities, we are able also to deform in a negative way the patient. So it's very, very important that whoever works with Chenot types of braces needs to know what he's doing and needs to be really well trained. Of course, there are nighttime bracing. So we have here the compression technique where the patient is compressed and because of a lying position, the spine is in a hypercorrection position. Unfortunately, we know that only nighttime bracing nowadays is not sufficient as a long-term result. I just wanted to show you this picture from an 1852 book of body treatments and bandages. And nowadays there are also systems which are very similar to it. But the spine core has proven to be positive for adults with pain situations in the spine, caused by scoliotic deformities. Unfortunately, the spine core has not shown repeatable results for children which are still growing and seems to need a stronger correction. Another elastic system was, for example, the triac system. We have here a quite strong system, which is just allowing the patient an inclination, but still in a three-point system attacking the deformity. The interesting thing here is that it is quite very, very cosmetic. Unfortunately, again, you have very, very specifically to take care that you just select those patients who are able or who are qualifying with their type of scoliotic deformity for this kind of bracing. If you have adults who need bracing, then typically you have pain and other negative effects of a scoliotic during working days. So we need here some correction, we need here compression, we need a reclination to give those patients over the day a stability to take over their daily job. Sometimes post or pre-operative situations are limiting our possibilities of biomechanic improvement of the spine. So what we do there is then just the circumference compressing, a stabilization of the body, which is barely correctable, but we have to stabilize the children who would otherwise collapse further and further in their deformity. The same for girls, boys, which for what reason, however, are not able to get operative treatment. The only thing we can do here is a reclination, a compression, and by compression, elongation of the body to fight against gravity and the deformation. If we have Prader-Willi syndrome or other genetically or hormonal imbalances, we have to take a lot of other points into our consideration. There are mental problems, and there are typically in this special group very big weight problems which have to be taken into consideration. So typically you have a stronger, stiffer frame construction with a more elastic textile abdominal fixation to adjust to the weight increase. sometimes deformities and defects are getting so strong that while you would like to correct them, you would take into danger to even damage the body in other parts. So there sometimes we have to make compromises till we get just one aspect of a patient right, for example, just a sitting corset, so that the children can take part in the school and not rely on their hands to stabilize their trunk. Colleagues from Switzerland are doing constructions with a joint in the side for CP children, so that they can they can guide their wheels on their wheelchair. And now I would come to the next step, because now we have scientific, we have new materials, and now, even now, we are actually completely leaving the manual part. So we are entering the digital, the 3D printing area. We know that we already for some time now are able to scan patients and to do modifications on the screen. But now for 5 years already, we are in our company going one step further, and we are constructing the braces which are then being able to be printed. So what we are doing, you have your scan of your patient and you do the rectification as you do it typically now, more or less. But instead of doing then a carving and the CNC or the polyurethane foam, we are constructing this kind of brace in a virtual digital way. That means that everything has to be constructed. You have to construct the profiles, you have to construct the perforations, the thickness, you have to construct or take into consideration what kind of area you might need to adjust, so that when the patient is then in front of you and is changing either immediately, for example, because the brace is prolonging the spine, or while the children are growing, of course, so you have also to have in mind that over a year or longer, the brace is still functioning and you have enough material. So there is much more planning necessary than you would do it with a traditional bracing. And then we use this FDM method. That means this plastic is melted in layers on each other and performing here some kind of making an object in this way. The special thing with this method is that we can do honeycomb constructions. That means on an object, not everything you see must be one solid piece, but we can have air inside. We can make hollow constructions, which are then material saving and lightweighted. Basically, the whole 3D is still very young, at least in our branch. And so we are already for 5 years working with it, and for 4 years we are constructing and designing our own printers. There is at the moment not a real 3D printer available who is performing like you would like that to be and to work with. Some impressions how our braces are looking like. Most of the time we try just to keep as much away from material as possible. We try to reduce and we try to improve the microclimate between the braces and the patient. There we can use the strong materials, the new materials, to give the patient as much freedom or air as possible. At the same time, I want the patient, when I make the fitting, to be as accessible or as easy to be used. So I don't need special materials. I want just the material to take care or to be able in the workshop to reshape it as all the other materials. And of course, the materials need to be tested so that the patient doesn't take damage while using those plastic. Plastic doesn't need always to be very flammable. There's quite some very toxic plastics available. So you need to take care about that. Here's some reclination brace where we use the reclination, the elongation, and some kind of compression of the abdominal area, but still try to keep the brace airy and open. What is very nice is this digital work. Just here, one example is that you can compare results from the year before with the next construction. So you get a really close idea if something is working or is not working already without an invasive documentation like X-ray. Some pectus carinatum braces, for example, here for a girl, always have been very difficult because we don't, of course, want to compress the breast, but at the same time we need to correct the sternum And with these new materials, that is now really easy and very cosmetically done. Very small braces. You see that boy here is still wearing diapers, so we can make very small, very filigrane constructions, and still the material is strong and stiff enough to take the forces which even such a small patient can bring to such a construction. Nowadays, all our braces are printed in one piece. We have the thermoplastic material. It's a polypropylene mix. And the most important thing, everything is normally possible: grind, polish, heating up, reshaping it if something is not optimal. And the braces are very durable. Even after 16, 18 months, we have not seen any kind of breaking or fatigue material. The future will be very, very interesting. Still, we aim for even more function in the braces. We are really constructing the braces, and we don't want to imitate the PE braces. We want to construct something new. So we will bring in more individuality. Right now, 2 patents are ready, close ready to be filed. And we expect also new materials. Nearly every month, new materials are offered on the market. And the machines, I think we are now planning our 3rd and 4th machine. And they, again, will be different than the other machines which we have already built. So this is an ongoing development. The last point is why I'm so high and so hot on the 3D printing. When you see what we produce on waste, when we make a classic brace, it's close, we're between 70 and 80% of the material are actually thrown away. And with 3D printing, per brace, we just have 120 gram of waste, which actually is able to be reused immediately. Thank you very much for your attention. I hope I'm not overstepping my time too much, and sorry for the delay in the beginning. Thank you very much.
Thank you, Mr. Würsching. It was a very nice presentation. So I go with the next presentation, which is held by physiotherapist and orthotic technician, Dr. Garikoitz Aristegui from Spain, who has his PhD in public health and epidemiology. He is also the teaching coordinator of BSPTS concept by Rigo and also SOSOR 2021 San Sebastian host. Mr. Aristegui, the screen is yours.
Okay, hello. Thank you very much. The first thing that I would like to say is to thank you, Deniz Aktan, and also to thanks to Nicola Jepke for the work that you are doing, because at this moment with the COVID-19, we are having a lot of problems to meet all of us together, and it's very difficult to organize a normal symposium congress. And I'm sure that to develop this possibility with this platform and the thing that we are doing, the webinar at this moment, it's really hard. Congratulations for the work. And also, I would like to send from here, from San Sebastian, a very big hug for everybody that is having problems with the COVID-19. I have a lot of friends in Brazil and also in Argentina, and I would like to send from here a very big hug. Okay, thank you very much. Now, at this moment, we are going to speak, or my idea is to discuss a little bit. I'm a physiotherapist, and also I am an orthotic technician, and I would like to discuss a little bit about how both work together. Okay, we know that the Scoliosis Society definition of the scoliosis, idiopathic scoliosis, is characterized by a lateral curvature of the spine of more than 10 degrees with vertebral rotation. Okay, but if we take the SOSOR definition that Rigo, Grivas, and O'Brien did in 2010, idiopathic scoliosis is a complex three-dimensional deformity of the spine and trunk which appears in apparently healthy children and can progress in relation to multiple factors during any rapid period of growth or later in life. What is the thing that we can start thinking here? For example, that the first definition is more about the structure, more about the spine, and the second one have more relation with the other parts, the quality of life and also putting in contact and putting in relation the trunk and also the pelvis. Okay, if we think one moment about one possibility that, for example, this girl has a scoliosis or has some deformities, they go with the parents to the hospital, do the assessment, Adam's test is positive. After the X-ray, the thing that doctor is going to say that the diagnosis is scoliosis. Okay, what happened now at this moment when the diagnosis is scoliosis? We have as a reference the SOSOR guidelines that SOSOR published in the 2018. And here we can see that, for example, in this case, we are speaking about one scoliosis, right thoracic and lumbar curve with more than 50 degrees. And this girl is going to do exercises and also brace. Okay, who is going to do this work? Orthotic technician who is a physiotherapist. Perfect. As orthotic technician, what is here in Spain, the work that he does? For example, first, he needs the prescription. After this, he's going to have the X-ray. Perfect. And then some of us have the possibility to work with the scan. Okay, we are going to scan the patient and we are going to do this work with a three-dimensional scan. And the result that the orthotic is going to have is the result is the brace that is going to send to different places. Perfect. As a physiotherapist, what is the thing that we do? For example, the first thing that we are going to do is the assessment, the postural assessment. Okay, and from here, during the postural assessment, taking in account the quality of life, we are going to define some specific exercises. Okay, we can say that now at this moment, orthotic and physiotherapists are ready to get married. Okay, but sometimes what is the problem? The problem, in my opinion, is one of these, in this situation, push more to some direction than the other that say, no, I would like to go to the other side. And this is the thing that I would like to discuss more, because in my opinion, they are ready to dance together and to get a very nice and beautiful honeymoon. Perfect. To do this, I repeat the same. We have the SOSOR guideline that in 2011 published, and then the second revision. And here is very clear. Look, this slide. Here in this slide, we can find the details to say when physiotherapists and when orthotics. I invite you to find here, but I am going to help you. Okay, here, for example, we can say, and we are going to find the physiotherapeutic scoliosis specific exercises. And now, in red color, look, in all of these moments, in all of these situations, we have the possibility to use the physiotherapy scoliosis specific exercises. Perfect. But also, we have the possibility to start with the brace. Rigid brace, 8, 12 hours, or maybe soft brace, or others. And look at this moment. If we put physiotherapists and orthotics work together, the situation is that we can convert, we can work a lot with the patient. We have a lot of things to do it, all of us together. Okay, why? Because we are in front of the patient. And if we work together, I'm sure that with the doctors, with the surgeons, physiotherapists, and also orthotics, we are going to find a very good result. But first, to do this, we need to define, in my opinion, what is the classification that we are going to use. For example, we can say, and speaking about the X-ray, we have all of this curve pattern classification. Ponseti, Mokettelson, King, Conrad, Lenke. Okay, perfect. For example, here, if we assess the Lenke classification, in my opinion, this classification is the palliative treatment. We can see only the spine. Also, we can see a little bit the pelvis, but we don't know what is the relation between pelvis and spine. We don't know what is the relation between the spine and legs. And also, we have the same situation with the Ponseti and Friedman classification. Perfect. I work in the Barcelona Scoliosis Physical Therapy School with Dr. Rigo, and we came from the Katerina Srov knowledge. And as you know, we can revise a little bit what was her proposal for the treatment, the 3D postural correction at first, orthopedic breathing to reshape the body, muscle activation and integration. And nowadays, starting in 2008, Rigaud created the BSPTS school. Okay. Well, what is the thing that we can see about the Rigaud classification? But the first thing that is going to use two parameters. The first thing is the clinical, and the other one is the radiological parameter. Okay. Now, the first, when we are speaking about the clinical, we are going to do the postural assessment. And when we are doing this, we are going to speak about the relation with the frontal plane. We are going to speak about the relation with the sagittal plane. We are going to find different prominence. We are going to speak about the relation between pelvic block and thoracic block. Also, we are going to use the original Rod classification based on the blocks. And we are going at the end to use all of this information to classify based on Rigaud classification. Here, for example, you have this slide with the blocks representation and the original Rod classification, speaking about the 3-curve pattern, 4-curve pattern, non-3, non-4, with, without lumbar curve, or lumbar and thoracolumbar. Okay, this is very good. This is nice. But I would like to see I would like to see when we are speaking and we are looking and watching the patient, we are in front of the patient, sorry. Here we have this 5 situation, and I repeat again, the first thing that in my opinion is one of the most important things to put together is the block system. Because if we start having in consideration this block structure and Rod classification, we have this possibility. Here we know how scoliosis is growing and is going worse. And now what is the work that we are going to do? This one, but not only the sagittal plane, not only the frontal plane, the work as physiotherapists, having in consideration the Rod block classification and also Rigaud classification, is that we are going to recover the position in 3-dimensional space and situation. Perfect. Nowadays, we know that we have a lot of information about this. We have more and more evidence. For example, the Bakuru research in 2015, the conclusion was superior to the home exercise and control groups. We observed that the scoliosis progressed in the control group, which received no treatment. And also, for example, the Sandra Schreiber article published in 2016, Rod physiotherapy, the scoliosis specific exercises added to the standard of care were superior compared to the standard of care. Perfect. Nowadays, published in last year, Karina Zapata in July, her conclusion was the physiotherapy, the scoliosis specific exercises resulted in significantly less curve progression compared with controls. We have information, and in my opinion, the concept by Rigaud, the idea that we have is work all of us together. First, medical doctor to do the assessment and diagnosis. Then physiotherapeutic, doing the physiotherapeutic scoliosis specific exercises. And then orthotics, in our case, doing the Rigaud brace. All of them working together, medical, physiotherapists, and orthotics. Okay, but I would like to say that at the beginning, the first thing is all of them, they need to have the same or to improve the knowledge that we have about the scoliosis, because scoliosis is a 3-dimensional progression and 3-dimensional pathological structure. Scoliosis has a transversal plan deformity. Before we learn that grow in those torsion and other mechanisms. But also, one thing is the knowledge, and the other thing is the concept. In our case, speaking about the BSPTS, we have different general principles, then we have the specific principles of correction, and we're going to define some strategy for the correction. Perfect, but it's not enough, because something is the knowledge, the other thing is the concept. At the end, the most important thing is how we are going to do the technique. Perfect. If we put all of this together, we are going to work, in my opinion, better. Perfect. When we are speaking about the general principle of the BSPTS concept by Rigaud, one of the most important things is the 3-dimensional correction. And I repeat again, I am not speaking now as a physiotherapist. I'm speaking of professional health, that I would like to put all of the knowledge that we have together. Medical, physiotherapists, orthotics. If we are working with the patient, the most important thing is to start with the three-dimensional postural correction. The second one, the thing that we use is the expansion and contraction technique. The third, muscle activation, and the last one, the integration. Okay, now, here, for example, I would like to revise a little bit. When we are in front of the postural assessment, when we are in front of the patient, we know and we can define some specific areas. And this is very important. This is very important to know what is the prominence, where is the collapse, and where is the pelvis. Yes, if it's prominent in one side or in the other, and how the shoulders are. We have the same situation when we are looking the patient in the anterior plane. Perfect. But I repeat again, when we are working as orthotics, doing, for example, the scan, we must recognize also all of these parts. Here we can see in the sagittal view and also in the frontal view, we can say that we have different parts speaking about the ribs. Perfect, this is a scan that we are doing. And look at this, for example, we can recognize different areas. And when we are working as a physiotherapist or orthotics, we know that we are going to put our contact there, or maybe not, but both must work together. Perfect. This is the work that we are going to do during the exercises, doing the 3D postural correction. And here, for example, it's very important to recognize what is the possibility that this patient has. Doing simple technique, we can say that we have the possibility to go from this point to the other one. Perfect, it's interesting. We can do the same if we do the work in the anterior view. Perfect, okay. But what happens sometimes? For example, this is the case that we had in our clinic. We can recognize very easy here, if we remember a little bit the pelvis that this patient has, we can say that she has a pelvis prominence in the left area, in the left side. And it's very easy now in this brace to recognize that the pelvis is in the same way. What happened? But for example, this is her X-ray, and at the end the result is the same. The X-ray that the doctor took to this patient is the same result that we have, in brace or without brace. But nowadays we know that we have the possibility and we have enough evidence to say that the bracing significantly decreases the progression of high-risk curves to the result for surgery and in patients with adolescent idiopathic scoliosis. But to do this, we need to know that we have some therapeutic window. And this therapeutic window came from the SRS recommendation for brace treatment. Adolescent idiopathic scoliosis reached to 25 degrees with the still potential to grow. We must work with the brace. Starting, for example, in the initial of rapid growth, we know that we have the peak and we have time after reset 2. We know that we are going to keep more time, maybe to the reset 3, and we need to assess other possibilities. Okay, here, for example, here I would like to say one thing. A brace is not an orthotic product, but it's a corrective device. What defines the quality of a brace is not the quality of the name, but the quality of the orthotics. It is very important. And sometimes, of course, and even the best orthotics will make someday a bad brace, because all of us are human and we can do something wrong. Perfect. Now, if we, after the scan, we have the possibility to define some reference, and we can see very easy the difference between pelvis, between a thoracic block, and we know where we can start working and pushing as physiotherapists. And at the end, orthotics must do the same here, here, and also here. if we work, for example, with this picture and define the same lines, the first thing that maybe we are going to do is to move the pelvic block. The second one is to move the lumbar block. And the third one is to move the thoracic block. At the end, it's the same work that we have done before with our hands. We are going to do in the frontal plane, and we are going, and theoretically, we must have the same result. When we are speaking about the second general principle, expansion and contraction technique, we know that the breathing mechanisms create an internal pair of force for the rotation and partial correction. Here in this video, we can see very easy this patient, how she can manage her ribs to decide where she wants to move and to put the concentration. We can see here how the right ribs move more than the left that go to the back. Perfect. This is the same that we have seen before. The work that we are going to do is this one, using this pair of force to start with the rotation process. Not only with as a physiotherapist, also with the brace. Here we can see this video, and it's very clear how in the right side, with the brace, we do some point saying to, this is the stop point, and in the other area, we are going to create a space to have the possibility to increase the volume there. Perfect. The third principle, general principle of the BSPTS is the muscle activation. Okay, and what is the idea? The idea is to start working to do this, not only with the muscle activation, also with the brace, coming from here to here, from here to here. Okay, having as a reference the Dr. Rigo article that he published in 2010, here you have the different pictures, and also it's very important to have the radiological criteria to define. Remember that we are not only speaking of the clinical criteria, we are putting together clinical and radiological. For what? To define what is the brace that we are going to do. This is, in my opinion, very important. If we decide, if we have the same classification, we are going to do the same work, and we are going to have, in my opinion, good results. Here you have the B or the 4C curve pattern. Here, lumbar and thoracolumbar. Okay, perfect. Lumbar, sorry, and thoracolumbar now. In brace correction depends on both patient and brace quality. This is very, very, very important, because when we are speaking about the result, and when family is coming to us asking what is going to happen now, if we take the in-brace X-ray, we have as a reference that the more than 50% is excellent, but less than 20% is poor. But be careful with this, because there are some, depends on both. For example, patient, depend if he or she has curve flexibility. The curve flexibility determines the percentage of correction with the ranks. And in brace correction can be predicted by assessing curve flexibility. Look, for example, this result. Because at the beginning, when we start with the first brace, we want to have the best result. And in my opinion, this is not the good way. We need to have patience, we need to have time for what? To have better result. But sometimes this 50% in brace correction is not possible. Not all of patients accept it. For example, last week in the ScoSym meeting, Dr. Murwa presented this interesting research and work that was received the award in the ScoSym Congress. Bracing outcomes in adolescent idiopathic scoliosis are associated with biological endophenotypes. Their conclusion, after controlling for independent predictor of severity outcomes and potential confounders, associations were identified between biological endophenotype classification group and clinical outcomes. There are some specific groups that received or had better result. And also in the SOSOR Congress that we have at this moment in the SOSOR website, this work that Nikos Karavidas did, predictive factor for successful bracing in the treatment of adolescent idiopathic scoliosis. His conclusion, our analysis revealed several risk factors for brace outcome. And this came also in his research that he did and he published last year. The most important predictive factors for treatment success are embrace, correction, and compliance, followed by cure magnitude and early growth state. And it's very important that physiotherapy scoliosis-specific exercises can further improve the treatment result, both going together. I would like to remember that 2017 in Lyon, Dr. Jean Dubosset, that he said, early horizontal plane and three-dimensional correction with a new brace generation. Be careful with the computers. Our brain, your brain, must remain the great computer. Okay, to finish and as a conclusion, in my opinion, idiopathic scoliosis is a complex 3D of the spine and trunk. No single concept explains all its complexity, but the Dubosset concept maybe can do it. Physiotherapists and orthotists should learn as much as possible about this complexity. Brace works, but they must do it better. In my opinion, where physiotherapists put his hands, orthotics must create pressure and contact with the brace. Where orthotics don't create a contact between patient and brace, physiotherapists must not touch the patient. Physiotherapists and orthotics and physiotherapists must always work together. And in my opinion now, we are ready to get married. And also we are ready to go to our honeymoon. And I invite you to come with us next year to San Sebastian to celebrate the Congress, the SOSOR International Congress in April and in May. San Sebastian is waiting for you, and I'm sure you will never forget it. Okay.
Thank you, Gary. Now I can use the Gary word. And thank you for the nice video and the proposal also. We are very welcome. So our last presentation will be delivered by the certified orthotist physical therapist Maksym Borysov from Ukraine, who is a senior instructor of Best Practice Academy according to Katerina Schroed. And he is also owner of Orthotech Plus Rehabilitation Services. His presentation will be about standardized CAT algorithms improve patient safety in the brace treatment for scoliosis. Mr. Borysov, the screen is yours.
Thank you. Is it okay? Do you see me? Okay.
Hello again. First of all, I want to thank for the organizers, to our moderator, to all speakers for very nice presentations, and also for participants who join us today. So my topic is standardized CAD algorithm, improve patient safety in the brace treatment for scoliosis. Today, we know that many different kinds of braces presented for treatment for scoliosis. But braces standards are vary. We have a randomized controlled study by Weinstein, and the conclusion of this study that brace does work. But this study was about Boston brace and showed the rate of success about 70%. Also, we know from the international literature, we know that Chanot braces, Chanot type braces, have better outcomes than Boston braces. But also, the results of Chanot braces vary to an extent. Some studies shows us 50% of rate of success, some studies 90% of success. So it's high extent. Let's have a look on this picture. These two braces were made in the same year, and on the left we can see we can see patients with single thoracic curve, but on the left you can see old-fashioned Chanot style brace, and as you can see, sorry, my mouse. Sorry, I cannot show you on the screen. I don't know why, but you can see that the body looks like shifted to the right on the left picture, and on the right picture you can see that it's good shifting and overcorrection, visible overcorrection of the spine. Another picture you can see on the left. Again, these two braces were made in the same year, but very different standards. So on the right, you can see old style Chanot brace, and also this is single thoracic right thoracic curve. And in the brace, on the right picture, you can see that no any shifting, no any shoulder girdle recompensation. On the left picture, you can see good shifting and good overcorrection and good shoulder girdle recompensation. Another example, again, single thoracic curve, but on the right picture we cannot see any shifting and any correction effect. So it seems all our interventions should be standardized via CAD system, computer-aided design. For this, in our work, we use Scoliosis software. This is unique software which specially developed for designing spinal orthosis. And let me introduce Gensingen brace. Gensingen brace is a modification of Chanot brace with individual design with computer-aided design. So for designing this brace, we use augmented ladder short classification with 7 types from 3 to 4 curves. And we have in our library, in our standardized library, 7 basic patterns on each side, 2 special patterns to each side, special models for adults, and anti-kyphotic patterns. Here is an example of 3C brace. You can see single right thoracic curve. You can see the body shifted to the right side, and in the braces like mirrored. Here is a 4C model, so you can see that the pelvis shifted to the right, and in brace is shifted to the left, and the same with the upper part. This is a single lumbar curve. This is a short brace, so we don't. If we have no curve on the thoracic part, we not necessary to use a big brace, long brace. So we're using short brace, and again you can see we have good shifting of the pelvis. Without brace, patient's pelvis shifted to the left, in brace, in opposite to the right. Another example of thoracic lumbar curve is also short brace, and again we can see good shifting of the pelvis. Initially, pelvis shifted to the right, and in the brace is shifted to the left. So how it happens? First, we collect data along with the X-ray, put it to the system. Then we scan the patient, crop the scan, scale it, and take the model from the library and initialize with the scan. Then we make with a certain algorithm, depends on the curve pattern, depends on the degrees and flexibility. We make some modifications of course it's fast and short, but usually takes much more time. Then we check everything with our measurements in different levels. And after this, we convert to STL file, which we can carve or which we can print. And basic principles which we use, of course, we based on the original Chanot principles, but we also use original Schroth principles. We try to shift the blocks, like look at the right picture, like during the exercises, we try to overcorrect, clinically overcorrect the curve, like mirroring deformity. So when we have good shifting, we have good, now look on the right picture, we have good in-brace correction, good shifting, good in-brace correction, like with exercises. And this is example for the fur curve. Initially, we have right thoracic, left lumbar. During exercises, we shift the blocks and we have, and the girl looks like with left thoracic and right lumbar. The same shifting we use in the brace, and so good shifting, good in-brace correction. Let's have a look on treatment examples. This is three curve, main thoracic curve. You can see on the scan and on the model. So you can see that the model is mirrored the deformity. So we make less, we make good shifting. And this is the same you can see on the body. Without brace, the body shifted to the right side, to the convex side, convex thoracic side, and in the brace, the body shifted more to the left side, and so we have good in-brace correction, more than 60%. The same for the four SIM models for double major. You can see scan and the model like mirroring the deformity, and good shifting, good in-brace correction on the picture. This is a short model. You can see the scan and compare with the model. So we have the same mirrored effect, and look at the patients on the picture on the left. Pelvis shifted to the left, in-brace shifted to the right. So good shifting, good in-brace correction. Huge deformity, 60 degrees in thoracolumbar level. Again, look at the scan, look at the brace model, good shifting, good in-brace correction. In some cases, this is VCN model with the knee drop pelvis. In some cases, when we have single curve and it's flexible, we can achieve slight overcorrection. And for the big deformities, like 50 degrees, at the final slide, I will show this girl with end results. We will back to her, but at the moment, this is in-brace correction. So you can see that in brace, we're trying to make the curves balanced. So we're trying to put both curves as close as possible to the midline to make the balance. For the huge deformities and for the patients who refuse surgery, we have a special model with a retraction strap. And again, the main goal in these cases is make the balance. here is another example, curve more than 70 degrees. In the brace, you can see we make like double major. We try to balance the curve. And on the left picture, initial picture, you can see collapsed trunk, collapsed body. And in the intermediate result, you can see well-balanced trunk and good cosmetical appearance, much better than before. So we're trying, and when we balance the curves, these curves will less progress in future. So let's show outcomes. 50 degrees in the beginning, 16 at the end, and well-balanced trunk. When we have not so big curves, we can achieve, in single curve, we can achieve slight overcorrection, and at the end, almost straight spine and well-balanced trunk. And if you look on the top of the initial picture of the patients, you can see flat back on the thoracic part, and at the end we have good sagittal realignment in the thoracic part. Another example is curve more than 40 degrees. At the end of, in the beginning, at the end of treatment, we have well-balanced trunk, and we also have nicely leveled rib hump. Initially, we have a single thoracic curve. At the end, we have better balance, but we have very good reduction of the rib hump. Double major curve. You can see good in-brace correction, good shifting, good in-brace correction, and at the end, we have well-balanced trunk and very good reduction of the rib hump. Again, double major curve. We see an initial picture, intermediate result, and end result with well-balanced trunk. Another example, single curve, good shifting, good in-brace correction, and very good outcomes at the end. Again, for the big deformities, at the end, you can see that the curve become like S shape. Initially, it was like C shape, like single thoracic. At the end, we have double major, but look at the body. At the end, it's more balanced and more stable, and more symmetrically. Start with 43 degrees, end with 20 degrees, and very nice shape. This is long-term result. Initially 38 degrees and at the end 19, but this 19 degrees still after 5.6 years after winning of the brace. So the studies which we made and which recently published, the success rate in the preliminary as well as in the end result cohort studies is the same. It's not so big difference, and rate of success about 90%. So we have studied one group with SRS criteria with 25 to 40 degrees, and another group was patients with more than 40 degrees, and preliminary results and end results were comparable. Also, we can use a brace for treatment with chronic low back pain if the exercises is not being effective. This paper, this study from our colleague from our team from United States, it was represented on World Congress with this study about patients with curves more than 40 degrees and with risk of 4 to 5. And Dr. Marmarko concluded in this Congress that we can achieve very good balance at the end, even with reserve 4 and reserve 5, and in some cases we can reduce some degrees. From the last year, from conference in Istanbul, another our colleague, Dr. Budi from Indonesia, made the study and concluded that the higher correction specific braces with CAD design can be effective to maintain and reduce deformity in AIS, late adolescents and adult patients with single lumbar curves, and also this can help with low back pain. So more information you can find in short textbook of scoliosis and other spinal deformities, which recently printed. And we have more than 40 centers all over the world. We're still developing, and we still try to standardize all this intervention to have the same results, repeatable results in different countries. And at the end, I want to share some information of quality of life. This is that lady with from Norway. This is her on the top. You can see her initial situation and intermediate result. And at the end, she's performance dancer. And this result is 2 years after winning of the brace. And last year, she was a winner of Everyday's model. And another example, very nice lady. She started with Reserve 4 in 14 years old, and she used a brace for 3 years. And at the end, she had very nice shape, body shape, very nice balanced trunk, and now she's working like a wedding model and has good quality of life. Thank you for your attention.
Thank you, Mr. Borysov, for a nice presentation. It was very nice. So, dear gentlemen, finally we came to the end, and I want to thank you for the informative and interesting presentations, especially. And right now, for our audience, ladies and gentlemen, we come to the question and answer session. I read a lot of questions on the question and answer part. I will start with a few questions. Some of them already are answered. So the first question is to Mr. Yılgör from Enyon Kala. Hello, a question for Dr. Çağlar. Which would be the ideal time to use the brace for the patient during the day, and how important to regulate the hours of having the brace on and off?
Thank you for the great question. So I think this is also the answer is in the loads that the spine is bearing. So when we are laying down compared to standing up, we have almost 2 times more loads, and compared to standing up and sitting, we have 4 times more. So actually the time that we need most of our spine to be in a straight position is when we sit, is like during the day, and then when we are standing, and then nighttime. And the braces on and off should be regulated generally according to the activity level of the patient. So whenever they are doing sportive activities, improving muscle strength, they can be off brace. But it's not like, oh, the doctor said I should use it for 20 hours, so I have 4 hours left and I can sit very crooked in front of the TV. So it's not going to work like that. But I think, again, the principle is to get the loads in the midline for as longer as possible.
Thank you very much. The second question is for Mr. Alanay. He wants to answer his life. Older people who suffer from advanced, from advanced scoliosis and would like to improve the quality of their lives, can they apply for surgery? What is the age limit to operate?
Well, I think to answer this question, actually, I would be happy to hear what kind of patients and surgical options has been mentioned, because if it's a VBT.
Mr. Alanay, it's older people who suffer from advanced scoliosis.
Yeah. Advanced scoliosis, I don't know. I mean, if this question comes to me for VBT, there is no role for VBT for this kind of patients, because if there's any degeneration, I don't think that a solution allowing motion would be really great. And also it depends on your aim. So if the patient is suffering from pain or something like that, due to the degenerative de novo scoliosis, and if the conservative treatment doesn't work, I think then they are a good candidate for fusion surgery. So if he's mentioning about advanced, or let's say, I don't know what it's meant by advanced, but if it's a curve magnitude less than 80 degrees in an adult idiopathic scoliosis patient, then VBT may be an option to decrease the curve size and also to prevent the progression of the curve. But the main problem here, or my main concern, is the potential of tether breakage, because I believe that eventually those tethers will break sometime, in the lifespan. There is too much load over the ropes or the cord, so they may break. So in that case, actually, if it breaks through one level, it may not be causing a huge problem, or there might not be a need for revision surgery. But if the curve comes back in an adult patient, then I think there is a need for revision surgery, which would be mainly a fusion surgery. So because of that reason, we don't offer too much for adult idiopathic scoliosis patients. I'm not talking about de novo degenerative patients, so I don't think that there's any role for BBT. So we usually discuss with the patient, and if the patient says that, I want motion, so I don't want any fusion solution, then we can do, this surgery for that sort of patients. But as I said, I would be concerned about the future tether breakage in those patients. In the kids, on the other hand, we are hoping very much that because there is remodeling of the spine, even if the tether breakages at the later ages, let's say 20s or 30s, hopefully, like within the tooth brace, or the deformity doesn't come back as there was some remodeling of the spinal column. Well, we don't have that long-term follow-ups yet, so we don't know the answer of what will happen after the tether breaks, in even those growing patients, or in those patients who had this surgery during their growing period.
Thank you very much for your answer. And I have read here a question. It's an interesting question to Andreas Würsching. Do you additionally correct sagittal profile during brace construction? Do you take into account pelvic parameters, doing, for example, kyphosation, pelvic anterior posterior tilting, etc.?
Can you see me now? I don't know. Can you hear me? Okay. Yeah, basically it's possible. That's not a problem. It just depends on the status of a patient, and if we can do something, and of course we try to improve the pelvic alignment and also the static. What I'm also a little bit carefully with is that especially in the pelvic area, a lot of our kids show quite strong stiffness. So I'm basically, at least in the very first time when we apply a first brace, focusing more on an overall basic good alignment, and not focusing just on one big aspect. I try to avoid that I have a perfect result, but the child will not wear the brace because the correction or the pressure which is necessary or would be necessary to achieve this improvement is too much to be used to get used to it. So we try sometimes, not always, but sometimes, to have a more slower approach to it, especially with smaller children.
Thank you very much. And there is another question. Does VPT, vertebral body tethering treated patients, complain of pain after the surgery, and for how long? And could we continue the correction by short exercises safely, especially for the remaining hump deformity?
Yeah, I think this is a great question. First of all, they don't suffer pain as diffusion patients. The only pain that they have actually is due to chest tube, which is placed, after the inflation of the lungs at the end of the surgery. So after we remove the chest tube, they usually don't have too much pain. In fact, maybe any pain. So that's the reason why they return to their normal daily activities earlier than diffusion surgery patients. For short exercises, I was really very hesitant to start any short therapy in the beginning of my experience. But, we had to start short therapy in some patients, as I mentioned, who had no response to our first initial compression at the convex side. So just to initiate the Hütter-Volkmann law to work, we started some short exercises, and then and also bracing. And then we have seen that they really help us for some more correction. So, once we have more experiences, probably we might be starting short exercises earlier as a routine post-operative exercise for those patients to get more correction, of course, depending on our expectation. If we don't expect overcorrection, we can, I think, give more role to short exercises than bracing for those patients. Bracing, I'm a little bit suspicious because, most of those patients are patients who really doesn't like to wear braces, so they want to be, operated by this method. So they may not be, volunteer to get bracing, but for exercise, I think they should be okay. But I certainly believe that, both bracing and short exercise will have more role for the post-operative rehabilitation period of VBT exercises. But I don't know yet how safe it is or which exercise is really safe for applying after VBT procedures. Maybe we should work together on this.
Definitely. Thank you for your answer. I have a question for Mr. Aristegui. From a physiotherapeutic point of view, is formetric 3D, 4D a better way to assess and follow up the scoliosis than X-rays? Thank you.
Now, yes. Formetric 3D for the system is a good system, and we can use in the physiotherapist clinics because it's without radiation, and I think that we have a lot of information for the system when we use. But we must remark that always the gold standard is the X-ray, and when we take some X-ray from it, we can have a lot of information, not only about the cup angle. In my opinion, it's the same that we compare with the ultrasound system. We are speaking always about the cup angle, but we have a lot of information when we take X-ray. For example, the relation between pelvis and transitional point, what happened with vertebral sacral line, and more information that sometimes we don't speak about it. I think that it's very important to remark that when we take some X-ray, the only information that we have is not the cup angle. Cup angle is the inclination angle, and also we have more and more and more information. We can use, of course, the formetric 3D and 4D system.
But better to put them together, I think. Okay. There is a question to Maksym Borysov also. Two questions, actually. I will read them in a row. I apologize, but I don't see any control or correction in the rotation, tendency, tilt, or prominence of the pelvis in the Gensing embrace. Could you please explain that first? And the other question is, are the X-ray results in the sagittal plane also as promising as the coronal plane X-rays? Thank you.
Okay, thank you for the question. In which direction we're talking about shifting of the pelvis? Because during presentation we shift the pelvis. Do you hear me?
Yeah, the rotation, tendency, tilt, or prominence of the pelvis. I think the Mrs. or Mr. Vahbe asking all three dimensions. I don't know.
So I don't understand clearly this question, but anyway, we shift the pelvis and we work with the pelvis because every brace should correct the trunk in 3D in all three planes. And also we consider the sagittal plane, we create lordosis and keep space for kyphosis, to restoration of kyphosis. And of course we rotate and shift the pelvis.
Okay, and the question about the sagittal plane is also good, and they asking, are the X-ray results in sagittal plane also as promising as coronal plane X-rays?
We usually not, in the beginning we make sagittal X-rays, but we not repeat all the time. But from the pictures, you can see that it's also restoration of sagittal plane as well.
Okay, thank you very much. There is another question. Do you change the style of orthosis if you think that the other style will be better in the duration of scoliosis follow-ups? That question is for Andreas Würsching, I think.
Yes, of course. Basically, I mean, the whole idea of our profession of making and constructing braces is to use all techniques. That was the basic idea of my presentation, that we have a lot of ideas, a lot of technical strategies, and meanwhile a lot of materials to achieve this for the patient. So it would be actually a failure in our profession if we don't change something when we see that something is not working like we like it to do. Okay, so of course there are the easiest question is that when I have for example a very anorexic patient, then I will probably use one type of construction, while when I have a patient with its overweight, then I will have complete other material choice on the other side. So and when patients are changing their shape, we have children, they are growing, they are changing. So of course there are factors which can change so dramatically that I need to be flexible enough to change my construction.
Thank you very much. The last question of today, because I have only 20 minutes and I always go up, so that will no have end. The last question is to Maksym and Garikoitz. How do you think that Schroth method is treatment skill or just exercise? I think we need a lot of medical information about human body to treat scoliosis patients, but a lot of athletic trainer, yoga trainer try to deal with scoliosis patients. How do you think about this situation? Both of you, 1 or 2 sentences, please. First, Mr. Aristegui.
Okay. Thank you, Deniz. Okay. The first thing, we know that the physiotherapy with the scoliosis specific exercises have enough evidence to say that we are working to treat and we are working to improve the scoliosis. When we are speaking about the patient, we are speaking about the scoliosis patient, we are speaking about the specific pathology. We are speaking about the health. We are speaking about the health problem. When we are speaking about the health problem, we are speaking about who is the person, who is the idoneous professional to treat this patient, is the health professional. Yes, and this is a very important point to say. I don't have any problem to work together with a yoga trainer, with athletic trainers, or with others. But when we are speaking about a specific pathology, the professional must be a health professional. Medical, doctors, surgeons, nurses, physiotherapists, and always, I repeat the same, all of us, we must work together.
And I also want to add about medical documentation. Of course, we have some contraindication for Schroth therapy, and of course we should consider this. And about sport, yes, now some trainers, some yoga instructors try to handle with the scoliosis, but it can be like add-ons, because this is not specific training. This is just general training. But short therapy, this is specific training according to the curve pattern.
I agree totally to you. So, ladies and gentlemen, finally we come to the end of our webinar. We would like to say thanks again to the presenters for the informative and interesting talk, and to the audience for active participation. Hopefully the presentations will be beneficial for everybody. Thank you for your attention. We wish, as the ScoSym team, a nice weekend.
Thank you.
Bye-bye.
Bye. Have a nice weekend.
Yeah, bye-bye.
Yeah.